First up this morning, I'm pleased to welcome to the TEDMED at CDC stage Dr. Judy Monroe, who will be presenting Medicine Meets Public Health on a Rocky Road in Appalachia. Dr. Monroe.
Thanks. So I have to start off with a confession. I never planned to have a career in public health. This is the last place I ever planned or thought I would be. My plan was to be a family physician. From a little child, I thought I really wanted to be a doc, and one of the things I wanted to do was to practice in an underserved community. So that was my dream. I learned along the way about the National Health Service Corps. It was a match. I took on a 4-year commitment, and I found myself in Appalachia, in rural Tennessee, practicing in the largest geographic county in the state, and I was ready to go. I was out of my residency, I had all this great training behind me, and I hit the ground running. Or so I thought I would hit the ground running. Those first few weeks of practice were incredibly stressful. I wasn't real sure what I had walked into. First, I was the first female in the county to practice, and my oldest son was a newborn, so I was a little bit of an anomaly and a bit of a curiosity in this county. And so people started flocking in to see the new doc. But women's health in particular really struck me. The women that were coming in out of the mountains to see me, sometimes for trivial matters were their complaints, had fungating breast masses. They weren't even aware of the breast cancer, the advanced stage disease that they had. Pap smears weren't even being done in the county. I think I did more pap smears in my first month than had been done in the previous 4 to 6 years. So women's health was a big concern. Then, one day I walk into the exam room, and here's a farmer, a lot of farmers in the county, walked in, and I said, so what might I help you with? And he says, well, you know, doc, every time I go out in my field, I get a pone in my leader, and I have to hunker down to make it go away. I thought, oh my goodness, what's he got? What's the diagnosis? Well, once I deciphered it and took a little time with him, I realized he was explaining perfectly in his own way intermittent claudication. He had severe vascular disease, and when he would walk and exercise, he'd get pain in his calf from the lack of blood supply to the muscles. He'd have to rest, make it go away. This was the tip of the iceberg. I found that patients in this county had cholesterols over 400. Tobacco was a huge issue. Tobacco use was really prevalent. And then injuries. Oh my goodness. Motor vehicle accidents, gunshot wounds, the farming accidents. I was running a little emergency room. They were rolling people in. One day I look up and here's a dad carrying his child, bleeding across the exam room, and another friend was carrying what looked like half the side of a barn, where the child had jumped out of a hayloft and had impaled their leg as they came down, and so their solution was just to take the barn to the doctor's office as well. And I saw all kinds of things with mining accidents and folks working in lumber and just an enormous number of accidents. But I kept scratching my head. One, I was overwhelmed with the number of folks coming in the office, but so much of this was preventable. And I had to stop and say, this is not why I went into medicine. I did not really want to be a family doctor and just see end-stage advanced disease or things that could have been prevented. And this goes way beyond the walls of my office. What do? I'm in a rural county, not many folks around. They didn't teach me this in my residency, but out of survival, I reached across and started a conversation with the local health department. It was a small county health department, but there were really committed people. There were committed public health nurses in this local health department. And I started sharing, and in those days, we didn't have the data exchange. I didn't have electronic health records. I had only paper charts, but I had observation of the county through my office. And I was able to begin to share with them what I was seeing, and they were sharing what they knew, and we partnered. And it was through partnership that it was my own survival, but also my own satisfaction in this practice to make a difference. And so over the course of the next 4 years, we were able to bring in mobile mammography. And by the 4th year of my practice, I wasn't diagnosing fungating breast masses that you could diagnose across the room. It was by mammography only. And we had taken on tobacco. And the only way to do that was to get into the schools. And I knew I'd made some difference when the parents were walking in saying, okay, help me with quitting smoking because my kid tells me that you were at the school and you said I should quit. And so the kids are going home now telling me to quit. And we reached out to the media, the local media. We had a little radio, we had newspaper. I didn't learn this in my residency training, but it was the only way to make a difference in actually population health. We had to begin to mobilize the community, and it took medicine and public health in this county to do it. It took folks across the county line. A vascular surgeon, once he started to partner with us, brought in a vascular screening opportunity for folks. And again, each time we would do one of these things, it would raise awareness and people would start to talk, and we could go to the churches and get folks talking. And so it was a remarkable experience, and it really drove home for me the importance of public health and medicine working together. So I was wrapping things up, and I'm getting ready now to follow my husband into academia, when I get a call one day from McNeil Lair producers, and they told me that they were doing a documentary on healthcare in America because of all the problems that we were having in healthcare, and that the narrator would be Dr. C. Everett Koop. And some of you may remember at the time the Surgeon General. Now, when I was in practice, I was receiving mailings from him because he was notorious for really taking the bully pulpit, making public health visible. He took on HIV/AIDS, he took on tobacco, he took on children with disabilities. So I knew him well because I had leveraged what he was saying about tobacco in my practice. So I get a call, and so I said, sure, you can come out. And I thought that the television crew would come, the camera crew, and they'd do a little clip, and that would be that. So the day before the crew's coming, I learned that Dr. Koop himself is coming to my practice, and he's going to spend a day with me. So this was a big buzz in the county, and so this was a year after he'd stepped down from being Surgeon General. So he arrives the next day. I didn't rest well for a number of reasons the night before. I was a little anxious. My husband kept trying to give me quiz questions, what he might ask. That only made me more anxious. And so I was a little tired, but Dr. Koop shows up. We have a wonderful morning in the practice talking to patients and folks in the community, and one of the things they wanted me to do was to make a home visit with Dr. Koop. And they wanted us to spend a little time together, so they wanted me to drive alone with him while all his entourage followed. So we start out on this windy road, and we're off to see a child that I was caring for, and I made a lot of home visits during this time, to see a child that had been born with a very severe neural tube defect. She had a large occipital encephalocele and she'd lived longer than had been expected, and so there were a number of issues with the care. And this was of interest to Dr. Koop, given his being a pediatric surgeon and having dealt with children with disabilities. So we're driving along up the windy road. And did I mention that I was term pregnant with my third child? And so as we're driving along, I start having contractions. And Dr. Koop, being the astute clinician that he is, looks over, he recognizes what's happening, and he says, if it's time for the baby to come, there's no problem at all, because I've delivered about 80 babies in my day, and we can just deliver the baby here in the field. Now, by this time, he has also informed me that he is the second most recognized individual in the United States. So he's telling me, no problem. For who? It's no problem, right? And all I could see were the headlines. Can you imagine? Dr. Koop delivers unknown woman in the mountains. But luckily, my daughter held off for 2 days, and I had a few I wasn't comfortable, but we made the home visit. He saw this child. He actually turned to me at one point and he said, if I had the right instruments, I could do the surgery on the kitchen table. So anyway, we talked about the care of this child, and we did a walking interview down this rocky lane in the mountains. And of course, that's the part that they aired on national television for this documentary that, by the way, he won an Emmy for, and I waddled on national television with Dr. Koop. There's the proof. I was pretty big at the time, delivered 2 days later. But that brings me to a topic that's dear to my heart, and is something now that is a priority for our agency and really a priority for our nation, and it's gaining momentum, and that is this intersection or the integration of medicine and public health. Our agency, CDC, along with HRSA, funded an IOM report that was published last March on this integration, and this is the spectrum that was in the report, that medicine and public health can be all the way in isolation, where we don't know one another, we don't even talk to one another, all the way to merger. And I think personally the sweet spot is in the collaboration, the partnerships and the collaboration is really where the sweet spot is. And we have a lot of drivers right now. With the Affordable Care Act, that's a driver. Our economy is a driver. If you look at what's been called the triple aim or the three-part aim that CMS is all about, we want to improve health care and the quality of care. We want to drive down cost, but population health is that third piece. And I think it's incumbent on us here at CDC, and we are partnering with the Centers for Medicare and Medicaid Innovation. It's an exciting time to see our agency working with HRSA and CMS on these efforts, but it really is incumbent on us, all of us, to look for where the opportunities are to find the sweet spot and the synergy that can take place to make a difference truly in population health by reaching across the aisle and finding out what our colleagues in medicine are doing and that they know what we are doing. Many of us came from medicine into public health, and I think it's our charge to do this. So thank you.
Our format in the room is going to be slightly different than the format that we watched on the monitor a moment ago, in that we have the opportunity for a question or two. And so let me ask you to expound a little bit on this window of opportunity of idea. Is there an example that CDC can learn from for how we could apply that to some of our work?
Yeah, we're looking now at the best practices. If you go to the IOM report, actually, there's some nice examples. And one example I'd point to is around asthma. Asthma costs billions of dollars every year. It's one of our chronic diseases. There's a lot that we can do for it. And if you go to Durham, North Carolina, they actually had tried an intervention where they were trying it only through the medical side of the house, and it didn't gain traction. And then when they started to work together with medicine and public health and really brought forth all the tools with better care in the doctor's office, better education, getting into the schools, getting into the community, raising that awareness, putting all the structures in place, the environmental factors, the data around where the hot spots are in the environment, all the things that public health does, they ended up making in a very short period of time a real impact in asthma and driving down hospitalizations and emergency room visits. It was so successful they've gone statewide now. And so it's a great story. If they couldn't do it one or the other by themselves, they had to come together.
And so as a quick follow-up, that would be sort of the sweet spot that you were talking about a moment ago.
Yeah, and I think we have it in every disease if we look creatively and we talk with our colleagues that are in medicine.
Thank you very much, Dr. Judy Monroe.